Hi, I am Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are
Two Peaks in a Pod.
Well, welcome back, everybody. Okay, Dr. K, I'm mad at you.
Oh, why?
Okay.
Why today?
Because yesterday you were telling me about your health ring and how young you are. Okay. So we both have health rings now. We're tracking our sleep and our hormones and all these things. And one of the things you can do is find out your age. And I am 2.5 years older than my stated age. I literally look too. I'm aging by the month. This happens like in the last month.
Oh, jeez. That's a little questionable.
And I did have a rough month. Maybe it was just me being sick, but I've never been younger than my age. And would you like to tell everybody how young you are?
I don't know how these biometrics are calibrated, but I am very proud that I am 6.5 years younger than stated age.
Oh, you're so lucky.
I actually logged in to check, though. I'm like, does it think that I'm really old? And it's just...
And so I've been asking everybody who works here has one. All my patients, I have tons of patients that have these. Everybody's younger except for me.
Really?
What is up with that? Yes.
Okay.
What's wrong with me?
Here's my theory, though. You had yours for a while. I feel like you were one of the OGs, right? Like, how long have you been wearing yours?
I mean, I don't think that long. Just from, I think, November maybe or something like that. So, yeah.
Because I do think it's kind of a ploy. Like, when they first have you tracking, they're probably like, oh, yeah. Like, you're so young. And then they're going to be like, oh, look at you. You're aging. And then you're going to want to track your data more to improve it, right?
I do. Yeah. I'm like, how can I get younger? Actually, I did see too when I was looking, they have a little 6-minute walking test you can do. So I'm going to do the 6-minute walking test.
It's definitely an old person test.
And I want to see, can I get my score to be better? If I'm a good fast walker, my heart rate responds appropriately, maybe I can get younger.
I remember from my geriatrics rotation in med school that the walking test is definitely for Jerry's.
So this is only added, like, it's if you hit the button to do the walking test, like, that just added 5 years. Yeah. Only old people do the walking test. Okay, great. Okay, well, I'm very happy for you guys. This means Dr. K is going to be around for a long time, and I'm going to be working on it, and I will keep you updated. Okay, so I hear you have a celebrity to tell us about today.
Okay, this is like my generation celebrity. I absolutely love her. Mandy Moore.
Oh, yes.
Okay.
Okay.
First of all, she's reinvented herself because she's on a very popular television show.
Oh, what is she
This
on?
Is Us, right?
Oh, did you watch it?
I watched it like when it first started.
Okay.
But I feel like they did very well. It was a very popular show. I actually don't know if it still has new seasons.
I've never seen it, but I heard it was rather emotional. And I was like, I don't know if I need something like a little less deep sometimes.
Yes,
to watch.
Same for sure. But she's awesome. I think she's like such a good like female friend, like she's a girlfriend type of celebrity. Yeah. Always positive. And I guess when we were looking, through celebrity stuff, she definitely has come out before that she had her own fertility struggles, right? Okay. And I guess when she was trying to get pregnant, maybe most recently, Mandy, you're gonna have to write into us and tell us if I'm getting your story wrong.
I'm sure she'll be right on
that. Okay. At Peak Fertility, you can DM us. Yes. But my understanding is that she was kind of getting this workup, right, to figure out why she wasn't getting pregnant this most recent time. And her fertility doctor had suggested that he or she was suspicious of endometriosis. Okay, which I feel like is fairly common, right?
Sure,
we often have patients where we do a workup, they come back with unexplained infertility. We talk a lot about how one explanation for unexplained infertility can be endometriosis.
Sure.
But then I guess like right when she was about to go for surgery to confirm this diagnosis of endometriosis, she got pregnant.
Oh, good.
So it's a good story.
I like the story.
Yeah.
Okay, good.
But I will say her fertility doctor was doing the standard of care way to diagnose endometriosis, right? So this is what you and I were taught for years, right? The only way that you can officially diagnose endometriosis is to take someone to surgery, take a small sample of cells called a biopsy, have a pathologist look at it and say, yes, this is endometriosis, right?
Well, and even more specifically, a camera in the belly button, inside the pelvis. Sometimes we have another procedure called hysteroscopy. That's a different thing. We can't see endometriosis on that. But yes, with the laparoscopy, we can look for endometriosis. And yes, we have to not even see it, but biopsy it.
Yeah. So that, I mean, I've been getting that spiel my whole career, right? I'm so used to explaining that in kind of layman's terms. So, however, ACOG is our governing body of OBGYNs, and it kind of sets the standards, the gold practice and standard guidelines for OBGYNs across the country, has recently released new guidelines for endometriosis, which is really exciting.
Absolutely.
Our lives are kind of boring. This is exciting for us.
I know. I'm sure I've been telling my patients about this change like over the last week. And I think they're like, why is she so excited right now? And again, let's bring up the age thing. I've been doing this for a long time, for many years. It's always been the same. And then they change it. And I'm like, oh my gosh. And they change it for the better, I think. And we're going to kind of talk through that. But I want to break down this Mandy Moore story a little bit because from what I understand, she's kind of saying she got misdiagnosed, right?
Yeah, I do feel like the article's message was that she felt maybe her fertility doctor misdiagnosed her because she got pregnant, right?
Yeah.
But I think there's a little bit of a cautionary tale there, right?
Yeah.
You can still get pregnant if you have endometriosis.
Yes, exactly. Endometriosis can come with infertility and vice versa, but it doesn't mean you can't get pregnant on your own. In fact, I would say probably most women with endometriosis are going to be able to get pregnant on their own. So I don't want to create any fear in women at all who've been given a diagnosis of endometriosis prior to ever trying to get pregnant, right?
Right. And I do think a lot of the purpose of sort of rebranding our guidelines is to validate women, right? For so many years, women have really struggled with healthcare providers to get accurately diagnosed with conditions such as endometriosis. And I think that these guidelines, a lot of the goal is so that we can believe women and understand what they're saying and treat them without making you jump through a ton of hoops to get treatment.
Yes, absolutely. Yeah. So I would say my opinion on the Mandy Moore story from the details we know is I don't know that she's been misdiagnosed. That may have been correct. She may have had endometriosis or she may not have, but either way, I think it's always a good thing to be thinking about during somebody's fertility journey for sure. So,
Mandy, let us know if we're misrepresenting you.
Okay, so let's talk about all these new guidelines. I'm so excited to talk about them. So previously, the gold standard was you had to do laparoscopic surgery and take a biopsy of a lesion to know you have endometriosis. The new guidelines say you don't have to have surgery. Yay! I always love the more natural stuff. I'm more granola, crunchy. I don't want my patients to have to undergo invasive things unnecessarily. So I think that's why I'm so excited about these guidelines. So, but if you don't have to have surgery, then how do we know if you have it? Well, it's based on what you tell us. Isn't this nice? ACOG's listening to women. And so an important part of your doctor seeing you is that they should be listening to your symptoms. Are you having painful periods? I do think this can be hard, right? Because probably everybody has a little bit of cramping with their periods, okay? Usually what we're meaning is more severe cramping. So for me, trying to describe that is if you've ever had to call into work or miss school because your periods are so severe, or if your period pain has ever been so bad that you've been to the ER, those are kind of red flags for me, right? I would say that is more than just the average cramping there. What are some other symptoms that we might hear from patients with endometriosis?
Pain with intercourse, pain with bowel movements, and sometimes they can have pain not on their periods, right? Of course, if you're coming to see an infertility specialist, infertility is one of the symptoms of endometriosis. So we kind of think about that as like that triad of things that go together. And so ACOG really says you kind of have to put the whole picture.
Yeah. And let's dig into the pain with intercourse a little bit more because we actually see quite a number of patients that have difficulty having intercourse due to pain, but there are different locations at which that pain can occur. So you can have pain on the vulva or in the vagina, or you could have pain deeper inside. And I think most classic for endometriosis would be that deeper pain that you can feel. However, sometimes when people have had intercourse and they've had that deep pain, they can develop more external pain because it's almost like your brain is saying, oh my gosh, anytime anything comes in here, it makes it painful. So let's try to keep anything from coming in here. And so you can get these muscle squeezes or muscle spasms. We call this vaginismus that can be connected to kind of the ultimate root of possible endometriosis there as well.
How do your patients describe endometriosis pain to you?
Well, it's interesting because I can sometimes tell when somebody thinks they have endometriosis when they come in or not, right? When I have somebody who's never heard of endometriosis, oftentimes, and this is crazy, they kind of feel like, oh, there's something wrong with me. I'm a wimp. And it makes me so sad, you know, because they'll just be saying, gosh, like, oh, my periods are so painful, but I am really sensitive to pain and everything. And I'm like, I don't think you are.
Yeah.
You know, it shouldn't feel like that. To them, they're just like, oh, I thought this was normal and it was just me.
Yeah.
It just breaks my heart. Whereas when I have somebody who comes in and has kind of done their own reading and education and everything, oftentimes they'll be even saying those keywords. I have dysmenorrhea.
Oh, yeah.
And I'm like, oh, she's been studying.
Yeah. You know, this is just like anecdotal. I feel like I do have quite a few women who tell me it feels like a knife in their abdomen turning.
Oh, okay.
And that, I don't know. I've meant to like kind of look into this. But for some reason, they all, like many people describe it as like this feeling. And I don't know if it's just like that's what people say as an extreme abdominal pain or something, but that like twisting sensation of, and so I'm like, whenever they say that, I'm like, oh, and we do have a wonderful doctor that we work with a lot who specializes in endometriosis surgery. So we do see a lot of, endometriosis patients that have had surgery and had really severe, you know, findings in their abdomen. And so I've kind of like taken note of that. And I ask people, I'm like, how did it feel for you? And a lot of people say like that. It sounds pretty bad.
Yeah. Oh, that's heartbreaking. I mean, it's hard to be a woman.
I know. And for years, I feel like there was kind of this mantra of, well, you know, women have pain, you know, your period is painful, you know, and now I think that we're kind of trying to not normalize that, you know.
Well, I think that's almost what it is when somebody gets a diagnosis of endometriosis, they suddenly feel like, oh, that's why. That now you have your why, and you also have your people, because it's nice these days with social media and internet groups and everything that you can find these groups of other women who are going through exactly what you've gone through. And it's nice to know you're not alone.
Yeah, absolutely. You call it your tribe.
Your tribe, your endo tribe. And it's great because those women also connect with each other. They help each other and all of that too. So I think that's wonderful. And so, you know, really, I think what ACOG was trying to achieve with these newer guidelines is they were trying to help women get to treatment faster, because what they were describing is that because women would need surgery to get a definitive diagnosis, providers weren't always offering the treatment that they needed. And because a woman may delay surgery for many years, they found that for some women, it took about 7 to 8 years before they can even get the treatment that they needed. And so their goal, by loosening up how we diagnose endometriosis, taking it from a surgical diagnosis to a clinical diagnosis, the purpose or the intent of it is that they're trying to help women get treatment faster.
And that really can't be underestimated. Okay. Because endometriosis is a progressive disease. It's going to get worse as you get older. We cannot really emphasize enough how important it is to have an early diagnosis, because then if you get your diagnosis when you're 25, right, before you're even thinking about having children, you are going to be much more responsible when you're thinking about your own fertility and what's a priority for you. Maybe that's not a priority for you, right? But you're probably going to go see someone a lot sooner if you are having trouble getting pregnant. Not all women with endometriosis will have issues getting pregnant, but if you know you have a diagnosis of endometriosis early, you're probably going to do something about it sooner.
Yes, absolutely. And I do want to just touch on one of the treatments for endometriosis that I know you and I both feel is very protective for fertility. And I know online there's a big debate about birth control pills overall, right? And everybody can feel a little bit differently about it. But let me just kind of say this. When you're on birth control pills, your ovaries are not ovulating, okay? If your ovaries are quiet, they don't have the opportunity to form cysts which can later become endometriomas. These are what some people call chocolate cyst, okay? Once a woman has formed an endometrioma, it's very unlikely that's going to go away. And birth control pills have been shown to lower your chances of getting an endometrioma if you have endometriosis by 50%. I think this is so important because endometriomas absolutely affect your fertility. It lowers your ovarian reserve and may even affect the quality of your eggs and subsequently the quality of your embryos and everything too. So I know if I were a young woman with endometriosis and I wasn't currently trying to get pregnant, I would absolutely be on birth control pills to prevent ovulation and to lower my chances of getting endometriomas. But then I think there's another benefit to birth control pills too, which is suppression of menses too.
Mm-hmm. Yeah, absolutely. One of the theories behind how we even get endometriosis is backflow bleeding, right? You can take continuous birth control pills and get fewer bleeding episodes in general. You don't have to completely knock out your periods, but you can get it down to like 1 or 2 bleeds a year, and that's going to help. Not to mention, most of the pain that you're going to have from endometriosis related pain is when you're actually getting the period itself. And so if you have fewer period events, you're going to feel better. Your lifestyle is going to be better. Your pain scores are going to go down. So there's a lot of advantages to being on even continuous regimen birth control pills. Also, birth control pills are known to kind of suppress those endometriosis implants that I kind of imagine them as like little inflammatory factories in your pelvis, right? Mm-hmm. And so endometriosis really can help to put a lot of those little factories to sleep.
Absolutely. Mm-hmm. And then the other nice thing about progesterone pills is so most of them have 2 hormones in them. And sometimes people get a little concerned because we do think that estrogen or estradiol can stimulate endometriosis implants. We know that can happen. And yes, birth control pills do have a little bit of estrogen in them. However, the bigger component to birth control pills is the progestin component. And we know progestin is very suppressive for endometriosis. So because birth control pills are overall progesterone dominant, that really kind of takes away the risk with estradiol pills as well too. Mm-hmm. So for multiple reasons, multiple mechanisms of action, I think birth control pills are a great contributor to preserving your fertility later on in life. I think that's important to hear for women who are sometimes hearing opposite messages. And unfortunately, I've even had patients who come in themselves who were on birth control pills for maybe some other reason. And they say, well, I wish I wasn't on birth control pills. Birth control pills gave me endometriosis. Mm-hmm. And I say, no, that's not true. You know, it's maybe coincidence that both of them happen together or whatever the case, but it's important to get the facts behind that too.
Yeah, absolutely.
Mm-hmm. Okay, so Dr. K, let's say I'm your patient. I come in and I say, you know, Dr. K, I've been having trouble getting pregnant. I do get really painful periods. What's my next step? How can you help me decide if I have endometriosis?
Yeah, well, one aspect of the new ACOG bulletin and guidelines say that we should use imaging to help us to evaluate the patient. So I would say we need to get you in for a full physical exam. We never want to mistake abdominal pain for something that's pelvic or gynecologic in nature that maybe could be something else, right? Yeah. And so just listening to your history can help a lot, doing a physical exam and then doing some imaging that we do in office, like a transvaginal ultrasound can actually be really helpful. There's some really obvious signs of endometriosis on ultrasound that we can pretty much look at it and say, yeah, I think you have endometriosis, right? Yeah. Dr. Reed just mentioned an endometrioma, which is like a big ball of endometriosis. It's a cyst on your ovary. We have such good ultrasounds now that we can really look at a cyst and the particular appearance of it and tell you, yeah, I think this is an endometrioma. We can't be 100% sure, but we're fairly certain. And I would say that's another way that ACOG encourages us to say, yes, you have endometriosis, right? Yeah. There's even some newer imaging modalities and techniques to help us to kind of evaluate, can we see some of these endometriosis lesions on ultrasound with our sound waves and be suspicious there so that we can give our patients the diagnosis that they're looking for as well.
Yeah. And I'm really into this concept called dynamic ultrasound. And the concept is that traditionally when women have a sonogram, sometimes your doctor may just be seeing images, right? They just see this image, that image. But I really love the concept of getting to see your uterus and your ovaries in motion. And so, of course, to do that, either the sonography tech has to take it's called a cine loop. It's kind of like the video instead of the photo. Or it's very helpful if we get to do it ourselves. And so the concept is when you're putting the probe in, you're watching, does the uterus and the other organs slide freely, or does it seem stuck in place? Okay. If things are sliding freely, you say, great, everything's moving around like it should. But if something is stuck, you are logically assuming, gosh, if something's stuck, there may be endometriosis or scar tissue or something like that causing that to be. And then other things you can look at are there's special spots that endometriosis loves to live in. So probably one of the top spots we'll see is tucked right behind the uterus, on the uterosacral ligaments, and on the posterior vaginal wall. And so these are things that Dr. K and I are always looking for whenever we do an ultrasound to see, hey, are we seeing any little pockets of endometriosis there? Finally, the fallopian tubes. It's interesting because most people don't realize you usually should not see your fallopian tubes on an ultrasound. However, if you see them, it's kind of a red flag, because if you see them, they're probably swollen and filled with fluid. That's called a hydrosalpinx. If you see a hydrosalpinx, then we say, gosh, there's probably some scar tissue, and could that be due to endometriosis as well? And that leads us down a pathway to help you figure that out. So these are all things that we are always looking for. And it's interesting because this is all going on inside of our head as we're doing a very fast ultrasound. And so, this ultrasound may take 2 minutes or less, right? And then we take out the ultrasound probe and the patient says, well, did you look for this? Did you look for that? And we're like, yes, actually, these are kind of mental checkpoints that we're looking for as we are taking care of you. But here's the most important thing, which is, if everything looks totally normal on your ultrasound, we have not ruled out endometriosis.
Yeah. Right.
So we can rule in endometriosis. I may do your ultrasound and say, look, you've got these symptoms, you've got this suspicion on the ultrasound, I'm going to give you this diagnosis of endometriosis. But also, somebody can have no symptoms and a perfectly normal ultrasound and still have endometriosis. And I feel like on the patient side, that can be really confusing. Mm-hmm. But really, we're talking about these tiny little implants. Like, think of a mole on your arm, okay? That's what an endometriosis implant is. That's how tiny it is, but it's just inside of the pelvis. And so you can't always see that as well. But I think that's important to know, because many patients I see will come in and say, well, my doctor said I didn't have endometriosis because I had a normal ultrasound. And I would say, well, we still need to think about it as a possibility.
Yeah. And I think any of our fertility patients that are coming in that have had a pretty thorough workup and still don't have an answer, our highest suspicion for you is probably that you have endometriosis. We might not always be saying that to you. I feel like sometimes it just depends on the patient, right? Some people really want to know if there's something potentially, but we kind of always keep that in the back of our minds as a potential. And I would tell you that our treatment options are often considering that. Yeah. I think the other aspect of the ACOG guidelines that are interesting and actually have encouraged me a little bit to explore some other options is they encourage other imaging modality like an MRI to look at endometriosis. And I will say that I think radiologists, so traditionally the type of doctor that's going to read an MRI is called a radiologist. I think radiologists have kind of known that this is coming even before us OBGYNs, because I do send a lot of my patients for MRIs for various reasons. And I've gotten some of these reports back that are very detailed, looking for signs of endometriosis on an MRI. And I have often been like, oh, what is this radiologist talking about? Like,
they're coming for your job.
Yeah, like they would say things that they were suspicious for lesions for endometriosis. And I'm like, what? You can't tell that, you know?
In your lane.
Yeah. And now I'm kind of like, should I be sending more of my patients for an MRI solely for this purpose? I think that some of my patients would actually really like to add this to their diagnostic workup, right? Okay, you're telling me you have unexplained infertility. Can I go for an MRI and see if they see anything? I think that can be helpful. Now, I definitely think it depends on if you get a good radiologist. Not all of them, I think, are as well trained, but I have found a couple in the area that I think are really good at it.
I agree too. And it was interesting because a couple of years ago, I had a patient who came in. She said, I have endometriosis, and I'm looking through, she hadn't had surgery and everything. And I'm like, how do you know you have endometriosis? And she said, I'm a radiologist. I did an MRI myself and I saw endometriosis. That was kind of the first I heard of this too. And I'm like, really? And so because of maybe her personal experience, she has expertise in that. And so I actually consider that when I'm sending off my MRI sometimes to send to her, because I know she has such a good eye for it.
Mm-hmm.
But I have found not all radiologists are up to date on this.
Mm-hmm.
And again, maybe because they're looking at these teeny tiny little spots that maybe in the past didn't have much significance, but these days we really do like to know if that's the case. Now, I would argue that if we did an ultrasound and we saw the endometriosis on the ultrasound, an MRI is probably not going to be helpful for us because we already diagnosed it. So maybe a perfect candidate would be somebody who had a normal ultrasound and who really is just looking for more facts overall. I still don't think it would be necessary in that case. From what I understand, the guidelines are saying probably the people who are probably going to have the highest consideration for an MRI are people who are intending on going on to surgery. And the purpose of the MRI there is to let the surgeon know and understand how severe the endometriosis might be for surgical planning purposes. So, for example, if you can see on the MRI that endometriosis is implanted deep inside the rectum or the bowel, you may say, gosh, if I'm going to do the surgery, I want to make sure that there is a GI surgeon on backup if needed. Or if it's involving the bladder, you might want to say, maybe I should have a urologist available if needed or something like that. So if you have a patient who's not really interested in surgical management, may not be as important to do an MRI, but it's nice to know that it is an option these days too.
Yeah.
Yeah. I guess this does bring up a point now. So let's say you do an ultrasound on me and you're like, yep, you've got endometriosis. Okay, what do we do? I'm trying to get pregnant. You just told me I had endometriosis. Maybe I'm kind of happy to finally have an answer, but I'm also stressed because now I'm like, okay, like, am I going to be able to have a baby?
Yeah, absolutely. I feel like we have a lot of patients like this. I always sit down and have our treatment planning discussion. Whenever we're thinking about what treatment option would be best for you, I really do take into age quite a bit. I would say my younger endometriosis patients, I am very encouraging for them to try some lower level treatment options. When we think of treatment options for these couples, the idea is really to increase the likelihood that you're going to get a positive pregnancy test on a monthly basis and get you pregnant faster time to pregnancy. So we think about treatment options like medications to trick your ovaries into ovulating more than one egg paired with an insemination or an IUI. That's kind of one of my lower level, least involved, least invasive treatment options. I would say most of my younger, potentially endometriosis patients will opt for a treatment option like that. What about yours?
Yeah. And I really feel like people are sleeping on IUIs, inseminations for endometriosis patients. It doesn't get talked about a lot, but I really want to highlight the link that I think occurs between women who have a narrow cervix and women who have endometriosis, because usually when you have your period, it should come out. So if you've got a cervix that is straight and wide open, it's going to be easy for your period blood to come out. But if your cervix...
It's making me laugh thinking about a wide cervix.
Cervix, I know, right?
I don't want to be told I have a wide cervix.
Well, you probably do, and I probably do too, right? When you've had babies, you've got a wide cervix. It's just
flows right out.
Well, but okay, you brought this up, right? So you and I have both had vaginal deliveries for our children, right? When your cervix is wide open and you've had a delivery, endometriosis often heals after that. So you'll have somebody who had terrible endometriosis. If she does get pregnant and has a vaginal delivery, her endometriosis is better. So why? Her period blood comes out easier. Now, if somebody has a very narrow cervix, or if it's kinked, or I've even had a patient recently that had a cervix like a corkscrew, okay? Imagine that when your period blood is trying to come out, some of it is probably more likely to backflow through the fallopian tubes. And again, you mentioned that's probably one of the top theories of how endometriosis occurs, right?
Okay, so, I still would prefer having a nice little skinny, narrow cervix. It just sounds so much better.
A supermodel cervix. So I know the girls got to get on board with a big cervix. because I think a skinny cervix is not good for fertility. Okay. So,
sounds nice, but bad for fertility.
I think number one, a narrow cervix makes you more likely to have retrograde menstruation and more likely to get endometriosis. But number two, if you've got a narrow cervix like that, it's hard for the sperm to get through sometimes too, right? So how can we overcome that? insemination, right? So your husband may have completely normal sperm, but if it can't get through the cervix, you're not going to get pregnant, right? Well, when we're doing an IUI, we put a little tube through the cervix and we put the sperm past that point. Okay. And so I think, and we have data to show this, if you've got early stage endometriosis, fertility pills plus IUI absolutely increases your chances of getting pregnant. And so I think it's a great treatment, and people don't really talk about why specifically it's a great treatment for endometriosis patients too.
Yeah, I think it's a really good strategy, especially now, like you're a modern young woman, right? Go get diagnosed early. You're having painful periods, you're 22, go see someone, get diagnosed early, get on birth control pills, right? And then come see a fertility doctor sooner rather than later when it's time. And then we can tell you you're a great candidate for Clomid insemination, right?
Yeah.
That can really help you to avoid some of our bigger treatment options. So I think it's really nice. You got to kind of strategize your future. Everyone's a planner.
Yes.
You know?
Yeah. So I love these IUI cycles, but also I don't want people to waste too much time trying IUI if it's not working for them. Our data shows if IUI is going to work for you, 90% of the time it's going to work within 3 cycles. And so if you've done 3 cycles, it's not working, then I do like to step it up. Now, this is where I will admit some bias here. Okay. If you've done 3 IUIs and you say, what should I do next? It depends on who you ask. If you ask a surgeon, they're probably going to say you should do surgery next. And if you ask an IVF doctor, they're probably going to say you should do IVF next, right? So I think it's fair to admit that there's some bias there. I think they can both be great options. You know, because I tend to trend more natural, I view IVF as the more natural option when compared to surgery. Surgery is serious. Surgery can have complications. It can be risky. That is why there are only certain surgeons in our area that I will even trust. Okay. So I always think if it were me, I would much rather have IVF because I see that as a more minimally invasive natural option. And the great part about IVF is you have the opportunity for fertility preservation, to freeze embryos for the future. We know endometriosis is progressive and destructive. And so why not take this opportunity to get pregnant now, but also have embryos for the future?
Yeah. And I talk to my patients candidly too about what their goals are, right? Yeah. Some of my patients who perhaps have endo, maybe pain control and lifestyle is also one of their really big goals for their future, in addition to getting pregnant. And I will say there's absolutely data to support surgery for that purpose, right? Very good data to show if a woman is taken to surgery for endometriosis related pain, her pain scores are going to go down after surgery. And you might have some minimal to moderate benefits in fertility depending on the stage of endometriosis they ultimately see at the time of surgery. So it just depends, right? And I do want my patients through those options, you know, and a lot of people, I agree, want to avoid surgery, but not everyone.
Yeah. And then the other thing I would mention, just because I was saying how much I love IUI though, is if you know you have advanced stage endometriosis, we're talking severe stage 3, stage 4, IUI has not been shown to be helpful. And in those patients, you should likely go straight to IVF as well. So I feel like lots of great options for endometriosis patients. And now I feel like so many more patients are going to have access to this faster because they're not having to sit there and wonder, could I or do I have endometriosis? I guess maybe my last comment on it, my only hesitation with these new guidelines is, what if I say, so a patient has painful periods, I do an ultrasound, I'm like, I think it looks like you have endometriosis, right? I'm going to say you have endometriosis. Let's say she has surgery and they don't find any endometriosis, right? That's probably my only hesitation, is I think as doctors, we hate to be wrong.
Yeah.
Right?
Yeah.
And there is the potential for that. But here's what I would say is, even if we suspect it and we're wrong, these are still standard treatments that you would give to somebody who doesn't have endometriosis as well. So I don't think there's any harm. I think the ultimate best case scenario is that the scientists are going to keep working on finding non-invasive markers for endometriosis. And so while we're waiting for that to happen, I think this is a great
Agree.
Perfect. Okay, should we wrap it up?
Yeah, y'all have a good week.
Okay, perfect. Bye, everybody.